over 70% of those surgeries, in and out the same day, are performed at the more expensive hospital outpatient site of service. So these numbers that we have from the Blue Cross Blue Shield cost estimator are real North Carolina numbers. I'm happy to share some federal numbers, but the federal basis is for the future, at beginning 4 years ago, any hospital that builds a new surgery center off campus, off their central campus, they have to bill at the ASC rates. That is tremendous. None of these bills do, with certificate of need, define ownership. Expectation is that once these bills pass, the hospitals will come to terms with the doctors, they'll build a joint venture. But the patients will pay less, they'll have their surgery performed in a great setting, low infection, low cost. And for those who have no insurance, it's much less expensive to have their surgery performed at the surgery center. So we think this is an issue that the time has really come. The federal push is really there. We learned from Matt today, the advantages of having certificate of need don't do anything to save the patient cost or money. Thank you.
Thank you, Doc. I asked Dr. Matt Mitchell, PhD Matt Mitchell, a surgery physician, not to get him mixed up. If you would just summarize some of the high points of what you told us this morning at breakfast.
Sure. Yeah, thank you. Yeah, I let them all know I'm not a real doctor, so I hope anybody has an emergency, talk to one of these people. It's a pleasure to have the opportunity to chat with you today. So just real briefly, you know, as fraught as healthcare is as a policy issue, one of the nice things going for it is that the goals are really not in dispute. You look at the platforms of Democrats, the platforms of Republicans, both of them have as a goal three things: greater access to care, greater access to higher quality care, and lower cost for that greater access to higher quality care. Now the nice thing is both economic theory and the empirical evidence suggest that greater competition is in service of all three of those goals. You hear a lot of, for lack of a better word, sort of fear-mongering or scares about what would happen in a state without con. Well, the nice thing is we don't have to wonder or worry. We have now this national experiment that has been going on for 3 decades. Right now, 39% of the US population lives in a non-con state. This is a state where you can open or expand your healthcare facility without asking for permission and without expecting the incumbent providers to oppose you in doing so. And we can look at the experience of that 39% of the population. These are rich and poor states. These are states with all sorts of different demographics. These are urban, these are rural states. We can gather data on that type of, those types of factors. We can run controlled experiments, regression analyses that include controls for these types of factors, and we can see what happens. And the evidence is overwhelming. States that do not have these barriers to competition, they have greater access to care. They have more hospice care facilities. They have more ambulatory surgery centers per capita. They have more hospitals per capita. They have more hospital beds per capita. They have greater access to scanning equipment, and patients are less likely to go out of state for care. They're also less likely, there's fewer racial disparities in the provision of care. We find that in non-con states, health outcomes in terms of readmission rates, in terms of survival rates after heart attack and heart failure, they're better. And we find that costs are lower in states that have more competition. This is not particularly surprising to an economist. Most of our models do actually predict that greater competition leads to lower cost, higher quality, and greater access. It's also, incidentally, not all that surprising to antitrust authorities. This explains why, for decades, under both Democratic and Republican administrations, antitrust authorities and the Federal Trade Commission and the Department of Justice have taken the position that con laws are anti-competitive and harm consumers. So going back to the initial idea of what are the bipartisan goals of healthcare reform? They're increased access, lower cost, and higher quality. To me, it seems from that perspective, this is a pretty easy reform. Not saying it's easy politically because there are some special interests that are going to lose from it, and that's where the leadership of legislators who are willing to stand up for the general interest, for the patients, and for the physicians who aren't protected from this, that's where it's really, really important. So thank you very much for your time today.
I know some people in the room sit at typing and writing, notes and everything. Does anybody have a question they'd like to ask of anybody up here? Yes, sir.
I have a question. So have you made any projections on how much savings would be accrued by the states for, say, Medicaid, or for the state health plan?
Yeah, let me, there we go, perfect. Okay, so what we can do, again, what we know about CON, the effect of CON, is really derived from interstate comparisons, and these comparisons control for all sorts of other factors that might confound it. But it's estimated, comparing the outcomes in CON versus non-CON states, that total healthcare spending per capita would be about $213 less than it is currently, and physician spending per capita would be about $73 less in North Carolina without CON. This is based on the experience of states that have repealed. I wouldn't expect these outcomes right away. You know, some of these states that don't have CON haven't had it since 1987, and it takes a long time to build some capacities. But that's essentially what the economics models suggest in terms of cost savings.
Anybody else?
What if one of the senators could come up, talk about, you know, the politics of this, is that, you know, they've been trying to push this for years and it hasn't really got a lot of traction parliamentary wise, and I'm wondering whether the new Democratic-Republican balance here may lend itself to make this a negotiating component. Remember, Senator Heiss might be something.
I want to rub with the chin.
I was wondering what you thought. I mean, do you see the political environment here leading to potentially making this kind of a bargaining chip at the end of the session?
Well, I'll start to say that we have had a lot of success. I believe it's twice now the Senate has passed over to the House of full repeals of CON. There's definitely some changes in personnel in the House for this session that means some of the opposition leaders and others aren't part of the membership any longer. Let's go through what I feel confident moving right now is there are areas of CON law that we have had broad agreement from for a long time, particularly mental health and others, that they serve no value in the process. Even hospitals that have those bed spaces would probably hand those over to anyone else who would be willing to take them. This would coming in, the real question is centering around ambulatory surgical centers. That seems to be the kind of the tip of the spear of this discussion, and I feel like we've got really good movement on it. And I feel like it could move under the normal legislative process. So coming in, but we are definitely keeping CON and other considerations as part of any negotiations or agreements that come towards the end of the session, which hopefully will be very soon and wrapped up by the 1st of July, provided the governor will go ahead and sign the budget and let's get on out of here. So.
And I'd be glad to hear from any other senator, but I decided to single somebody out to get him up there. Thank you.
Unless you want to add something, that's fine.
No, I really don't, other than I just really appreciate all the conversation. I think there's been some really good conversations, and of course, these two senators have been great, given me great history on some of the things that have happened, and I think the fact, I know that when I first went on the SHIG, you were actually on it, and that's one of the first times I had met with Senator Heiss, so I know he understands it. I think I don't know that you ever understand completely SHIG, but being in there and going through the whole process and working on the state health plan, I think gave both of us an understanding about what all's involved. And it's a, you know, it's a big ticket, big item. It affects everybody in the state sometime in their life, and some people multiple times in their life. But I know that we can do some things that'll drive costs down and give better service. And all of us worry about rural counties. You know, we don't want people to have to travel 2 hours in some cases to get not only their specialty care, but their primary care. So I think as we go forward, there's going to be some other things that we'll be looking at. And again, I appreciate anybody's ideas. A lot of people bring things to the table, and I know that all of us are interested in with stakeholders about any of those items.
Yes, sir.
So you mentioned politics, and you mentioned rural care and rural hospitals. There's a confluence of those two, and the hospitals basically say, we don't want this because it will impact rural hospitals. So how do you address that, and what are you hearing from the hospital lobby?
I'm gonna let Dr. Mitchell address that because he addressed something in that question you just asked this morning at breakfast.
Thank you. So, the data show not only do non-con states have more hospitals, but they have more rural hospitals. The amount is about 30%. So, just in terms of what you would think would happen, this is exactly in line with what you would think. Certificate of need is a restriction of supply, and lo and behold, we find that it restricts the supply of care, and both in rural and in urban communities. I find it somewhat strange that you do encounter that argument that, well, if we allow certificate of need, it'll lead to closings of hospitals. I think the idea is somehow maybe that it'll take away these hospitals to survive on their monopoly pricing power. What actually happens is communities can support more hospitals, we find, when there's less barriers to entry, and this tends to lead to greater care, certainly greater provision of care, and then higher quality and lower cost. Does that kind of get at your question?
As far as the political aspect with the hospital lobby, I mean, what are you hearing from them? Have you had conversations with them, because they generally tend to want to block these reforms?
I have not, and I sponsored a deal in the House, and I have not heard from them. I don't know about the senators, whether y'all have heard from them or not.
We are meeting with the hospitals. We have been meeting with them. We've had all the stakeholders at the table, trying to get some agreement, trying to get some movement. But those of us here, this is certainly not a political issue for me. Two of my largest employers are hospitals. We just want what's best for our constituents. And we've looked at the data. We know what it says. There is no logical reason why these folks should not be able to, why we shouldn't have some kind of a free market in healthcare. So the time has come. It's time for us to reform Con, and Senator Heisenberg and I over in the Senate we are committed to it, and we're going to keep meeting with the hospitals, talking with them. We want input from everybody. We want to listen to everybody and do what we can to make it as painless as possible for everybody. But the time has come for it to happen. Senator Heiss?
Yeah, and just to follow up on that, make no mistake that if we, when we eliminate ambulatory surgical centers from CON requirements, Dixie is the #1 entity in the state to open new ambulatory surgical centers will be the hospitals. This would coming in, and hopefully they'll do that with partnerships and others, but the hospitals will expand in this state to meet the change in the market that's coming through. I'll also say that the CON issue as a whole is a complicated one and a pricing one for hospitals. There are multiple areas of CON where the hospitals find a lot of unnecessary regulations and others through the CON process. And I know even here in Wake County, we can kind of remember some legendary battles between hospitals here of the CON process and what it meant and where you could locate and others. And I don't think as an entity as a whole, they really have any interest in the government doing that. They just tend to like the areas that make it a little more profitable for them.
To answer that question about any hospital association lobbyists, I haven't had those, but Blue Cross Blue Shield has come to see me several times. The new CEO of North Carolina Blue Cross Blue Shield moved here from Texas, and he does not like CON laws. So I don't know whether that would help you with consideration there or not, but no hospital association. Now, I have met with some hospital administrators in the East, and I know their opinion of some things, and their opinion and mine somewhat different, but there is middle ground there for both sides, for me and them as well. Anything else? I think we've about used all our time. Well, thank you all for those who came. Thank you, doctors, for coming. I've evaluated everything, and I picked out who I want to have some surgery by, so I'll tell you later.